All right, we're here live again with Dave from NYC Pain MD, and we have some great information for knee arthritis sufferers, particularly about surgery versus other treatments. I spoke with Dave, and he has some great research showing that there's some treatments that can help prevent the surgery. Dave, are you there?
Yeah. Thanks for having me today. There's some really interesting stuff, and there's so much stuff now available as you dig on these medical research panels and things online that sometimes you just discover things that have been there for a while, and sometimes there's new things, but it's always very interesting and brings to light kind of what the mantra of our clinic is. And keep in mind, if you're listening, I'm a patient care coordinator and manager at the facility. I'm not a physician. None of this is meant as medical advice, but just for discussion, to introduce you to these concepts so you can make better decisions on your own and get proactive and not be just dependent on one or two single opinions from your doctor, but you understand the situations yourself, because these things can be pretty serious. But, we get a lot of questions, and people are always calling about they don't want surgery and what's available. And so, we've talked about this if you've heard any of our online webinars before. And I think a couple weeks ago, we introduced a phenomenal study that would appear in a journal of knee surgery by Dr. Waddell. And Dr. Waddell found that 75% of his patients that had bone-to-bone or grade 4 surgery, even after 7 years, still didn't need knee replacement surgery. In any other world in medicine, that would be considered a complete survivorship, anything over 5 years. So that's phenomenal. That means 3 out of 4 that thought they needed surgery didn't have to have it, or still haven't had to get it. And of those that tried it but ended up with surgery, they were also able to delay their treatment of knee surgery for 2 or 3 years. So only 1 out of 4 ended up with knee surgery when they had image-guided protocols of natural FDA-approved lubrication. There's another study that we came up with, and I'm going to talk about in a minute something called arthroscopy, which is different than knee replacement. But this came up in the Journal of Arthroscopy a couple of years ago. It's called the Journal of Arthroscopy and Related Surgery. Arthroscopy is the use of scopes where surgeons go in and use a scope, and it's not completely open joint surgery, and they can sew things together and trim things and try to clean things up. But there was a special study that came out, and it was done from one of the most famous hospitals. I won't mention it for various libel reasons and so forth. It's a positive article. But so the hospital went to 3 orthopedic practices right here in New York City, and they had patients that were earmarked for possible knee replacement. It was actually 989 patients. 1,366 knees were treated with viscose supplementation. That means lubricant. And so just to go back on the basic science, arthritic joints, shoulders, knees, hips, hands, ankles, when you don't have enough lubricant, and as we sometimes age, damaged cells don't produce enough lubricant. That lubricant is like oil is to an automobile. If you don't have enough oil, you grind away the parts. So when you don't have enough lubricant in your joints, in your knee in this case, you grind it down, the space narrows, and if you grind it down to the bone, of course, some patients end up needing surgery or having surgery recommended or submitting to it, etc. So these studies are very interesting because patients always want to know, what can I do to slow down the arthritis, feel better, move better, and try to prevent surgery? So the skinny on this, if you will, is that the results were all the patients in the surgery had grade 4 bone-to-bone situations in the knee. Grade 4, it's called the Kellgren-Lawrence scale. Again, 989 patients, 1,366 knees. So they reevaluated down the road. And of the 1,366 knees treated with this treatment, only 6.3% ended up needing to have knee replacement surgery. These results not only support or put a cushion, no pun intended, under the other study we talked about in the Journal of Knee Surgery, they just confirm what we've been sensing without a complete top-notch study out of our own office, that lubricating joints not only makes you feel better by cushioning them, allowing them to move better, mopping up inflammatory chemicals, as well as possibly stimulating new lubrication production from your own cells. But they actually can help not only delay, but it looks like they can help you possibly completely avoid these types of surgeries. So again, out of the 1,366 knees, only 6% eventually require, I'm reading from this, the improvement lasted 6 months or longer, and of the 1,366 knees treated, eventually only 6.3% ended up in knee replacement, which means that of the 1,366 knees, or 989 people, only about 30 or 40 of those ended up having surgery out of close to 1,000 patients. That means you have a 9 out of 10 chance that you could get a good result if you're a properly chosen candidate. So, and that's why we provide this high-tech, super high-level, precise, safe, image-guided procedure in our office, amongst many of the other things that are offered for those that need it. So that came out of the Journal of Arthroscopy. But since we brought up that term arthroscopy, I don't think we've ever explored this, you and I, Brad. We should talk about arthroscopy. What is arthroscopy? Arthroscopy is when a physician, well-trained, and they all are fantastically trained, by the way, no doubt, go in and sometimes they'll do, they might like scrape the knee. So if you're arthritic, to sort of like grind down the high spots might be a way to talk about it. Sometimes you'll have tears and they'll try to mend them or sew them together. However, this has been controversial for years, where there's been studies that a few years later, the patients that had surgery end up absolutely no better than patients that had nothing done at all. So they've had a very expensive surgery financially. Of course, there's some risk of infection, risk of surgical poor outcomes. There's risk of anesthesia issues and so forth. And people are getting surgeries that absolutely are not all that effective, if not effective at all. So in some of the studies that I picked through, the effectiveness of arthroscopic surgery, there is no difference between the surgery itself and a placebo. Brad, what's a placebo? This is a sham procedure. It's like taking a sugar pill instead of a real pharmaceutical. So with patients that thought that they had surgery, they did just as well as the patients that got the actual surgery. Now, there's another procedure done arthroscopically where it's called meniscectomy. You know, everybody says, oh, I tore my meniscus. I tore my meniscus. Let's start with, what is your meniscus? In the knee has 3 components, the inside or medial, the outside, the lateral, and the component behind the knee bone, the patella. But the meniscus lies between the bones. There's an inside and outside ligament. It's like a horseshoe ligament that creates a kind of like a gasket like in a car, so the upper bone can move on the lower bone. But so meniscectomy is the removal or trimming of these torn menisci or meniscuses. And so this is a common finding in MRI. But again, research, the outcomes with meniscectomy or removal or trimming of the disc is exactly the same as doing nothing. So these surgeries are being done. And there are times when there's a complete tear and it has to be surgically done, or when you get, I think they call it a handlebar tear, or a complete radial tear where the meniscus is popping up and down, and these should be trimmed and so forth. But, you know, in general, otherwise, it has not been effective for partial tears and so forth. And so this is very important to understand. And so patients with knee pain have to understand, well, what is causing their pain then? If the meniscus isn't causing pain and the surgery is possibly unnecessary or ineffective, well, what do I do? We've talked about the famous article that appeared in the Journal of British Medicine, BMJ, and the British Medical Journal found that 90% of patients above 50 years old, that actually those patients, 90% of them or more, knee pain comes from the development of arthritis or osteoarthritis, even if you cannot see it on an x-ray. That is at the start. It may be undetectable clinically or diagnostically. So if your knees are hurting and you have a meniscal tear in an MRI, it may not be why your knee is hurting. And then these surgeries are done and you don't need it. So if you follow along on that path, well then what should be done? We'll come back to that later. This article and some similar articles also talk, what about the effect of the over-the-counter medicines for these problems combined with arthroscopic surgery and so forth. So the effect of non-steroidal anti-inflammatories, Advil, Aleve, etc., less than half of the patients get even short-term relief. And I'm not sure if patients understand this, but there's a lot of risk to your GI system, your stomach, your intestines. There's cardiovascular risk, and there's even incidences of heart attacks from patients taking too many NSAIDs. And while we move along, and we'll have a whole tutorial on steroids, they've also found that these corticosteroids, they may give short-term relief, but that they have many severe side effects, and they may actually damage the cartilage, which we're trying to protect. But that was just an aside. Going back to general arthroscopic surgery, it does not seem to be very effective at all, particularly for arthritis. And so what should be done? Well, I'm not a physician, and every case differs. But if you are the 9 out of 10 middle-aged people with osteoarthritis, 40 and up, that arthritis is coming from a drying out of the knee. That drying out of the knee comes to the lack of synovial fluid or cushioning gel, and it's very simple and easy to go through a regimen of care. We're under guided imaging. Physicians that are trained properly and have the diagnostic equipment can simply put you through a regimen of relubrication of those joints. As noted by Dr. Waddell in his study done at the hospital, 3 out of 4, 4 out of 5, 6 out of 7 patients do quite well with this and ending up not needing any of this stuff. And of course, you and I have talked this at length time to time, and so that needs to be evaluated. And I know, Brad, that you have the ability to put up a number. The office does offer no-cost consultations and preliminary screenings to find out if we can help. So if you feel like you're in this ballpark, that arthroscopic surgery has been presented to you or knee replacement, you owe it to yourself to explore these other options. If our doctors cannot help, if our physicians cannot help you, of course, they'll refer you to the proper sources. But again, these screenings are done at no charge. You'll be evaluated closely, a history taken, a fresh x-ray, and our docs can let you know what the possibilities are for you. So that's the overview of the arthroscopic surgery and some of the updated research that I found more recently.
It seems like the research is finally catching up what you guys do there and the great successes you guys have. Could you talk a bit about the NYC Pain MD method and why it's unique and different and why you think it gets such great results?
Right. So the NYC Pain MD method, one of the things the physicians and I've overheard and had conversations with them is that there is a disturbingly high inaccuracy rate with some of these procedures. Now, even some other physicians will poo-poo this, but the data is pretty conclusive that without a doubt, at least 1 out of 3 joint injections will miss the spot. That's in the knee. The knee is more difficult than, not as difficult as the shoulder or hip, but it's still quite difficult. And why is that, Brad? Because when you're arthritic, remember, you've ground down the cartilage, and so the space gets more and more and more narrow. Like I wear eyeglasses, and if I try to thread a needle without my eyeglasses on, I'm going to miss over and over and over. And trying to thread a needle in the dark is you're going to have an inaccuracy rate. Well, when you're trying to get a thin, and again, patients should not get wound up about the needle because the knee is all numbed up. But when you try to put a thin injectable needle into a joint space that's narrow, you shouldn't go in there in the dark. Why would you? We have all this great technology that 100% confirms and reconfirms the precise accuracy of it. Why would you do that? You need to know and confirm that you're delivering that lubricant, that lubricating medicine, exactly where you need each and every time. Because you have a regimen of 3 treatments and you miss 1 or 2, you're going to have only gotten 30 to 50% of the proper medicine, and you're probably going to fail the procedure. And then, of course, you can end up in surgery. So you can see how important the technology is. And so that's part of the NYC Pain MD method. And also, part of that method is also aftercare. And we'll talk on another tutorial on special bracing. And this is the NYC Pain MD method, where we use this very accurate fluoroscopic imaging. A special arthrography is done where the doctor injects a little contrast media to confirm the injectable. And this is what assures you that that medicine is delivered properly. It does not guarantee any particular outcome, but it does guarantee that you have the best chance of having a response because the intended medicine gets where it's supposed to be.
You guys believe that you guys get greater results because of this, correct?
We definitely believe it. And you made a statement before that the research is finally catching up to what we've been seeing in the office. And, you know, or it was out there somewhat, and now it's just confirmatory. This happens a lot in medicine where doctors notice all these great results with certain methods, but it's very difficult to do the research, or it's so costly, or no one wants to do it. And so clearly you have to go somewhat by your instincts, particularly in a procedure where it's so safe to do. There's really little to no downside to having a joint space lubricated. These are natural medicines and so forth. But yes, we've been noticing, and we believe wholeheartedly that if you're not using imaging, generally speaking, your results cannot possibly be as good as they should be. And you're putting people's health and lives on the line if you don't do it the right way.
Aren't there some studies that show that the injections done with the imaging are superior to the injections done without the imaging?
There's a lot of studies that allude to it, and while there was a study done that I had just read about where they were talking even about in days gone by where they used steroid injections, they found that even a steroid injection was much more effective when you use the special imaging because it was accurate. And when you get these medicines outside the joint space, clearly you're not going to do as well. There was a study done by a Dr. Jackson who clearly found that, particularly in the knee, if you did not use imaging, you would miss the joint space at least 1 out of 3 times. And both the studies that I referenced, the study by Dr. Waddell down in Louisiana, as well as the study done here at a local hospital, definitely Dr. Waddell's was done under guided imaging. He stresses that, and so was the study here done in New York. So you have to use the imaging, and without it, I don't know that you can even trust any research.
Yes, and I know that when you talk to people who have had these procedures, and you see on the internet, on Facebook and stuff, you see people making comments and stuff that have had the procedure, and some of them it didn't work for them, and they make a comment that this stuff does not work. The procedure doesn't work. Could you talk about the difference between a procedure not working for an individual and if it doesn't work at all?